Hey guys, alright, we're talking uh, second series of the knee and related structures for the athletic training class. Yes, the first video, okay, we were talking about anatomy, including the bones. We started discussing anatomy of the ligaments and the meniscus, okay, and the different kind of location of where they were at. Today we're going to be moving into muscle anatomy, okay, on both front of the thigh, back of the thigh, okay, and those muscles that are encompassing the knee. So let's move into our next series. Okay, so the thigh contains some of the biggest muscles that we have in our body. Okay, we know, and many of us have heard, okay, that the front of the thigh, those muscles are called the quadriceps. Okay, it's actually the major muscles, the quadriceps group, is made up of four different muscles that work at the knee. Hence the name quad meaning four. And the four muscles that make up the quadriceps group are listed there. Okay, the first is the vastus lateralis, and it is located on the lateral surface, and you can see that by the red arrow here. Okay, and if you feel on your thigh, you can feel that, okay, right above the knee. The second is the vastus intermedius. This one you cannot feel. It is actually located underneath a muscle that we'll talk about here in just a minute. The third muscle is called the vastus medialis, and that is located with the blue arrow. This is usually when people are talking about their quads and they're very well developed. It actually almost looks like a teardrop, and sometimes your bodybuilders and your weightlifters will talk about the teardrop in their thigh, and this is what they're talking about. Okay, is that vastus medialis. Now, all three of these muscles perform knee extension. And the reason they only do knee extension is because they originate on the femur itself. Okay, the fourth muscle that makes up the rectus femoris, the fourth muscle that makes up the quadriceps group is called the rectus femoris. And we see that with this orange arrow, okay, right here. It's right in the middle of our thigh, and it's responsible for knee extension as well as hip flexion. Because of where it originates above the hip joint. So that's why it has two main movements. Okay, this is also why we cannot feel or palpate the vastus intermedius, because the rectus femoris lays on top of the vastus intermedius. We can palpate 3 out of the 4 quadriceps muscles. Okay. Another muscle that's located on the anterior surface of the thigh that has direct motion at the knee, okay, is called the sartorius. And it is difficult to feel in the thigh area, but we can feel and palpate its insertion point on the medial aspect of the knee. If you can feel the medial meniscus, you are feeling the sartorius tendon, because that tendon is interwoven in the capsule along that area of the the MCL, the medial collateral ligament. Okay, we can also feel it on the tibia. And this area is called the pes anserine. And the reason that you would want to know that area is because the pes anserine is actually the attachment point of 3 different muscles. And we'll get into that at a later slide. One fun fact about the sartorius, it is actually the longest muscle in the body. Okay, it runs from the medial aspect of the tibia and it goes across the front of the thigh and has an attachment point on the lateral surface of the hip. The sartorius. Its main motion is knee flexion, and it also helps with tibial internal rotation. So when the knee is flexing, okay, the sartorius is actually internally rotating the tibia, and it creates better movement on those condyles of the femur. Moving to the back of the thigh, okay, the hamstring group. Okay, this is a posterior view. We have both superficial and deep muscles, okay, that we're going to be looking at. Now, if you look according to the arrows and the lines that are on the screen, your hamstring group is made up of 3 different muscles: the biceps femoris, the semitendinosus, and the semimembranosus. The biceps femoris is responsible for knee flexion and tibial external rotation. And you can see that it is located with the red arrow. Okay, the biceps femoris is located on the lateral side of the thigh. The semitendinosus and semimembranosus are both located on the medial side of the thigh. They are responsible for knee flexion as well as tibial internal rotation. Okay, because they're on the medial side, they're going to cause that internal rotation, okay, or movement towards that center line, okay, that imaginary center line of the body. So your quadriceps muscle is responsible for knee extension. Your hamstring group is responsible mainly for knee flexion. So we see biceps femoris, it's on the lateral side, this nice thick muscle right here. So when it comes down and it attaches on the lateral surface, okay, we have the semitendinosus in the green, nice thick muscle here, and it comes down and attaches on the medial surface. And then we also have the semimembranosus, which is partially underneath the semitendinosus, which then comes down and attaches very closely to the semitendinosus. And these are attaching on the tibial condyles. The semitendinosus has an attachment at the pes anserine, so it's actually wrapping around to the front, okay, to the anterior part of the tibia. So as we see here, big thing, the big black box. This is the medial side. It's just to help you guys so you can orientate yourself with these pictures. Okay, this is a very small muscle, the next one we're going to talk about, and it's called the popliteus. Now, the popliteus, it is very difficult to palpate because we have muscles that are going over the top, whether it be the gastrocnemius in the lower leg or whether it be the biceps femoris or the semitendinosus. Right? But the popliteus is a very important muscle. Okay, it's the prime mover, the main muscle that causes that tibial internal rotation. The reason that tibial internal rotation is important is a theory called the screw home mechanism. Now, when we bend our knee from full extension, the popliteus is going to start that internal rotation. And what it does is it actually helps to kind of unlock that knee joint. Okay, the bony anatomy, when the knee is fully extended, it actually kind of locks in place, if you can imagine that. Okay, with the way the condyles sit on top of each other on both the femur, as the condyles of the femur sit on top of the condyles of the tibia, as well as with the meniscus that's on the condyles of the tibia. The popliteus actually starts internal rotation before we actually begin knee flexion. So damage to this muscle usually occurs in an extended or hyperextended accident, because in an extension we're actually externally rotating that tibia. So think about coming down from, let's say you're getting a rebound as a basketball player, and you come down. Now they always teach you, don't come down with your legs locked, and this is the reason why, is because it's really easy when you're in that position for force to come and continue that external rotation as well as hyperextending that joint. So damage, when we think of injuries to that, this muscle is many times left out because it's such a small muscle that it's easy to forget. We think about the big muscles, we think about the ligaments, but damage in a hyperextended knee will most likely cause some injury to the popliteus. We're now going to go to a major muscle that is on the medial surface of the thigh, and it's called the gracilis. And its main motion is knee flexion and tibial internal rotation. This a lot of times is one of those muscles that people think of like as the groin muscle, and it's not really the groin muscle. It's a thinner muscle on the outer surface on the medial side, very similar to like the sartorius. It is more of a secondary muscle, okay, than a prime mover at the knee. While it does cause knee flexion and tibial internal rotation, okay, the sartorius is the main mover for tibial internal rotation. The popliteus is the primary mover for tibial internal rotation. Okay, it's a smaller muscle, doesn't have a lot of strength, but it is those muscles that we need to think about. So if you think about getting into like a splits position, okay, because its location on the medial side, you can have some damage and cause some pain to that muscle. So now what we need to really think about, okay, is what's called the kinetic chain. How everything is connected together and how everything works together, okay, to cause motion, to cause power, to cause strength. So when we refer to the word kinetic chain, this is what we're thinking about. How one thing leads to another. Okay? Everything is directly affected by motions and forces occurring at the foot, ankle, lower leg, thigh, hip, pelvis, and spine. So what does that mean? When you walk, okay, watch somebody walk. Their foot is going to hit the ground. Okay? As they start moving. Gravity is putting a ton of weight on the foot. It is getting transferred into the ankle, it's getting transferred into the lower leg, is getting transferred into the thigh, okay, that bone, which is then transferring into the hip, okay, the pelvis and the spine. Everything is working together to distribute the load. Okay, those forces have to be absorbed and they have to be distributed evenly and correctly in order for injury not to occur. If the body is unable to manage those forces, this is when injury happens. This is when a breakdown occurs. Okay, so when there's too much force, okay, let's say from jumping, as you come down, you now have force. The ground's not moving. Okay, so that force is traveling up the bones. And a weak point, or the body unable to manage that force, we can get a break in a bone. We can get an overstretching or a breaking of a muscle, a tendon, or a ligament. The knee is very susceptible to injury because of the amount of motion that can happen at the knee. Okay, any different angle changes the rate of absorption of those forces. This is why we see so many injuries in sports, is based on the amount of angles that we see injuries can happen. The way that foot hits the ground, okay, the way that somebody comes in and tackles at the lower leg. Okay, we have a lot of movement, and there's a lot and different forces acting in different directions. So this is where knowing the knee and knowing how everything is working together can help us create that picture in our head when they start talking about when you ask them questions of what happened. So we need to assess the knee. Okay, we need to get a good history. Okay, our acronym HOPS, HOPS. We're going to start out with the H, the history. So we have to determine the mechanism of the injury. This is a critical component. Okay, when I say determine the mechanism of injury, we're asking the patient to tell us what happened in their own words. They were there, they felt it, they have a better understanding of what happened because they were in the moment. We need to ask them when it says history, we need to ask them about their history. Sometimes you may know their history. Okay, if this is an athlete that you've had for multiple years or for multiple sports, you're going to know their history. And this is why keeping accurate data is important, so that you can refer back to that history of injury and see what you did to work, what you did that maybe didn't work. Okay, but we need to know it. We need to get a past history from them. Okay, if it's an athlete that you've never seen, this is why we ask them these questions. Okay, what did they tell you that it was? Okay, mechanism. This is what we're asking. What position was your body in? Okay, do you remember if your knee was bent? Do you remember if your knee was straight? Did they tackle you coming from the outside? Did they tackle you coming from the inside? Okay, all those type of questions are important because you are trying to paint that picture in your head and recreate the accident. Did the knee collapse? Okay, these are all different questions you can ask depending on the injury at hand. Okay, what type of sport were they doing? What type of activity were they doing? Were they just walking? Were they running? Was it during a high impact sport? Okay, you can ask them, did they hear or feel anything? Many times they might hear a pop. They might feel a pop. They might feel stabbing pain, achy pain, burning pain, sharp pain. Okay, they might have felt a crack. You can ask them, could they move their knee immediately after the injury, or did it feel like it was locked in it and the body did not want to allow it to move? Was there any initial swelling? Was there swelling later on? Okay, those are all things that are important. Where's the pain? When you're asking somebody where's the pain, it's a good idea to have them try to use one finger to point at it to see if they can actually determine where it's at. If you ask somebody where's the pain and they just say your knee, think back to all those pictures of the muscles and the ligaments. Okay, the knee is a three-dimensional object, and just saying the knee is very broad, and we're trying to get very detailed in how we assess that knee. These are some other questions that you can ask. What is their major complaint? Okay, when you're asking them, okay, does it hurt? Does it ache? Is it sore? What's the major complaint? When did you first notice it? Is there recurrent swelling? Does it get swollen? Does it come back? Does it lock or catch? Is there severe pain? Okay, do you feel anything grinding or grating? Okay, does it not move easy? Does it ever feel like the knee just wants to give out? Okay, or like a giving away feeling? That could be as you're walking. Basically, it just feels like your leg can no longer hold the weight of your body. Okay. What does it feel like when you go up and down stairs? Many times knee problems when you're going up and down stairs, this is when you start to see it, because it changes that angle and it changes the amount of force your body's putting on that joint. Okay, again, what past treatments have you undergone? If you don't know the patient, you need to ask that question so that you know what things they've had done before, because it can also tell you potentially maybe it's the same injury, and that you can also ask them questions on is this injury similar to what you've had in the past? Okay, the O section of HOPS, observation. You should observe them walking. You should observe them in like a half squat. You should try to observe them going up and down stairs if possible, and if it's safe. Okay, if they're hobbling and can barely put any weight on their leg, don't have them go up and down stairs. Okay, we need to use common sense in this. But these are all different normal activities that people do. So you could recreate steps for them in your athletic training room. Many times your gym may have some of those stackable steps. Put a couple up there, and that could mimic going up and going downstairs. Do you observe any swelling or ecchymosis? Ecchymosis is another word for bruising. Okay, what do you see in this section? The observation is, what do you see when they're doing these? Let's look at leg alignment. Okay, we have two concepts. We have genu valgum, and we have genu varum. Okay, that's the way that the legs look at the knee. Okay, genu valgum is almost like knock-kneed. Genu varum is bow-legged. Okay, knock-kneed, the knees, the medial sides of the knees touch. Genu varum, bow-legged. That's when you have a bigger gap. Okay, and you notice more of that bow shape. Okay. When you observe them, do they stand in a hyperextended? Is their knees hyperextended, or are they hyperflexed? Can they straighten their leg? Okay. You should also be looking at the patella. And we have patella alta and patella baja. Is one patella, does it look higher or lower than the other one? Okay. And you're checking both the injured leg as well as the uninjured leg. Okay, I don't have that on this slide. Okay, but that's extremely important. You need to be observing both legs. Does it look like the patella is rotated? Okay, inward or outward. So, when you're observing, you may have to be feeling. Okay, feeling or touch is a type of observation. Okay, let's look at the tibia. Does it look like we have, when we say tibial torsion? Okay, Does it look like one leg's maybe rotated? Is it internally rotated more than the other? Is it externally rotated more than the other? Femoral anteversion and retroversion. Does one leg, when they're standing, is one of the femurs, does it look like it's farther back than the other? All things that you can look at. Doesn't necessarily all mean something's wrong, but all things that you should notice, observe, and write down, because you never know, it could lead to something later on. So, we see here genu varum, okay, that knock knee, okay, where the knees, okay, are really on the inside of the ankles here. When you're standing up, your legs, your ankles should pretty much be right underneath your knees. And if you notice in picture A, okay, the knees are not directly over the ankle. In picture B, genu valgum. You know what? I need to fix this. This is incorrect. Okay. Knock knee is genu valgum. So I'm going to stop right here and I'm going to fix this, and then we will continue with this lesson at a later date. All right, guys. So as you notice, sometimes I make mistakes too. So that's one of the reasons that we're constantly looking at this, we're constantly observing, and we're constantly learning to get better. The knee is a really fun joint. The more you familiarize yourself with the muscles, with the joint, with the ligaments, okay, with all the different structures around the knee, you start to see how these injuries can take place. When somebody talks about, a certain injury, when you're watching them, this is one of the key reasons that observation is important when you're out there. We're not just talking with athletes. We're watching how they run. We're watching how they perform. Because certain people, they have these, they have these conditions, and that's a natural thing for them. Okay, you guys may know those people that are knock-kneed, that are bow-legged, okay, that walk maybe a little different. Maybe they got a little hitch in their walk. Okay, they may look like they limp, but that's a normal thing for them. You look at their feet, their ankles, how they run. Okay, observation is extremely important. I'm going to fix this slide so that way when you guys have it, we make sure that we're learning the right thing. And I will see you all next time.